Thanks, Jeremy. Thanks for having me, as always. I am going to, in the interest of bandwidth, turn off the video if that's okay, just because I worry this side of town, with signal, etc. All right, so we'll get straight into it. So I've entitled the talk, "A Filamentous Foe, Decoding the Nocardia Enigma." Um, and again, I think that anyone who spends some time working in a hospitalized environment, working with patients living with HIV, and certainly in an infectious diseases service will come across this. And some of the striking things are that there's usually or often a delay to diagnosis, and the treatment can be tricky, and there's some nuance to that. So I hope to clarify things. For the microbiologists on the talk, I hope there are a few. I have, because it has major clinical relevance, I have discussed some of the sort of taxonomic stuff and speciation because it does have relevance when it comes to treating this condition. So we'll get straight into it. I've got a couple of case vignettes that I'm currently working through, and then we'll work through some of the microbiology and taxonomy, some of the risk factors. We'll talk through a couple of clinical presentations, some treatments, the evidence or perhaps lack thereof, and some of the perhaps contemporary conundrums, for which unfortunately there might be more questions than answers. So, I mean, I'll race through these just for interest, just to demonstrate how varied and vast this disease can present. So this was a patient not so long ago that I saw, 30-year-old gentleman, person living with HIV, defaulted therapy, CD4 was 80. He was also a person who injected drugs, and he was an IV drug user. And this patient had a 2-month cough, constitutional symptoms, occasional hemoptysis. There was interestingly this area of fluctuance over the left lower anterior chest wall, which was initially missed because it wasn't really that painful. And only on a clinical and physical exam was it detectable. And he obviously had the usual, an X-ray that perhaps was convincing for tuberculosis, could be anything, given his risk factors. And because he was productive and pus was easily accessible, this was sent off. And gram-positive bacteria were noted on both samples. He had a positive modified acid fast stain, and his gene expert was negative. So this patient had nocardia. The next patient is a patient I'm currently busy with, a 70-year-old gentleman, HIV negative. So really a different spectrum, different age bracket, and he's currently completing treatment or has recently had therapy for a non-Hodgkin's lymphoma, for which there's been a partial response. And about a month before presentation, he had chemotherapy with his last cycle with R-CHOP. And he presents with seizures. And a CT brain and an MRI show this room-enhancing lesion on the right-hand side. And the neurosurgeons do their thing. They drain it. They remove the capsule, apparently. It's gram stain and culture negative, which, again, with anaerobes and things like that, perhaps not that uncommon. But they perhaps foreshorten therapy a little bit. Ceftriaxone and metronidazole given by the neurosurgeon. And so he comes back 6 weeks later with seizures once again. And repeat imaging shows this is a CT brain, shows the edemas there. There's still a collection. It's not so clear in these types of patients what's post-surgical and what's not. But you get the impression of reaccumulation and this marked surgical edema, in fact, worse than when he first presented. And that's 6 weeks down the line. And the pus was drained again, and it was culture negative. Luckily, this patient had a 16S PCR, which was sent, and that came back as a nocardia species. And ultimately, the second operation was culture positive, and susceptibility testing was obtained. This is, sorry about the histology showing its face, a 42-year-old male currently at Baragwanath, no known comorbidities, former employment in the landscaping business, and he had a 4-year history of a progressive, swollen, and deformed foot with these sinuses that drain intermittently. He says whitish little things that come out, occasionally a bit yellow. He's had multiple biopsies that are culture negative for significant pathogens. And this is the histology on the sample. And you can see these filamentous organisms sort of captured in the middle that are gram-positive staining. And then there's the Schoenlein-Hüppli effect, which is essentially all this eosinophilic stuff around it, and it's thought to be lots of antibodies and the like that stains in an eosinophilic way. There's a Gregos stain, which is negative for fungi, and a Quignon stain in this patient comes back as positive. So presumably a cutaneous nocardia. Nothing actually grows. All right, so getting straight into it. So nocardia, it's an aerobic saprophytic actinomycete. It's most commonly found in soil. So decomposing vegetation, other organic matter. It can exist in both fresh and salt water. So injuries or wounds sustained in that environment, it may well be on the differential, although it's not so common. It is an opportunistic pathogen usually, and then it can cause localized or disseminated granulomatous infections. The infection is usually acquired through the respiratory tract or cutaneous inoculation. There's a wide spectrum of disease. Cutaneous infections, as we mentioned, traumatic inoculation of the organism into a normal host can cause a granulomatous response. And then we get this subacute pulmonary disease, often in pre-existing lung disease patients or with varying degrees of immunocompromise. And then lastly, severe hematogenous spread to the central nervous system, that's in an immunocompromised host. They're obviously, like any other bug, you're going to find lots of cases of things that end up in weird and wonderful places. But if I was to summarize it, those are the three prominent and predominant sites of disease. So where does it fall in? Again, reviewing our microbiology. So it's part of your medically important gram-positive bacteria, and it falls here. If you look at under the branching filamentous gram-positive bacteria, and Nocardia differentiated from actinomyces by the fact that it's weakly acid-fast and it is aerobic, whereas actinomyces species are strictly anaerobes. The taxonomy is confusing at best, and I won't go too deep into the sort of backbone, but I'll go into some of the more recent recharacterizations of the organism itself. So it falls under the actinobacteria, and it specifically falls under your actinomycetales, and specifically under the Corynebacteriaceae, which again is interesting that it's related to good old Corynebacter species, of which there are many, some of which with more clinical significance than others. But we know common skin commensals, the causes of diphtheria, etc. And then within Corynebacteriaceae, you have a number of related organisms, including the Corynebacter species, Gordonia, Mycobacteria, and one or two others. So just to remind ourselves, because this is sort of where it falls into, we know that our cell wall is what differentiates both the gram stain and the uptake of an acid-fast type stain. So we have our gram-positive bacteria, again, with the standard all that I think everyone knows. We have our gram-negative bacteria with the lipopolysaccharides and the peptidoglycan layer in the middle. And then we have our mycobacteria, which also have some peptidoglycan, but they also have things like arabinose, galactose, and most importantly, these mycolic acids. And what's interesting is that including Corynebacter, all these species that are grouped together have some degree of mycolic acids, and the length of the chain, the number of carbon atoms, is actually what dictates whether or not they are not acid-fast, weakly acid-fast, or strongly acid-fast. So as you can imagine, for example, Corynebacter have very short chains, sort of less than sort of 20 to 30 carbon atoms. Nocardia, Rhodococcus, another organism that you may have heard of, these have around 40 to 60 chains, carbon atoms, so slightly longer, and that's why they're weakly acid-fast as long as you don't over-decolorize them. And then mycobacteria, which have lots and lots of these long mycolic acids, 60 to 90 carbon atoms per chain. And that's sort of what underlies this, and why, for example, Corynebacter is not acid-fast, but an Nocardia might be weakly acid-fast along with Rhodococcus. And for example, MTB or Mycobacteria we know are strongly acid-fast. So that's what it looks like. A couple of examples. On the far left, you can see a gram stain of sputum, gram-positive, beading, and branching. Those are some of the characteristics. On the right-hand side, again, another gram stain, slightly less clear-cut. Almost looks a bit gram variable. Again, that beading filamentous appearance. On the bottom left is a classical, on the bottom right is a classical Ziehl-Neelsen stain. On the bottom left. And on the bottom right is what's called your modified acid-fast stain. So again, a less potent decolorizer because the mycolic acids are smaller and it's more prone to losing the phenol-based stain. Culture is important for speciation and drug susceptibility testing. Now, the problem is this is where we sometimes lose it. You need an extended incubation time in some of these cases, 21 days for most samples, 28 days for blood cultures, which are very uncommonly positive. And it usually requires a median of 5 to 21 days for growth. They're characterized by this ability to form almost these aerial hyphae, almost like a mycelial growth, and to grow in media containing lysozyme, which again is something that's important in the host immune response. The fact that they can tolerate that allows them to persist intracellularly, and they can't grow at extremes of heat, sort of over 50 degrees inhibits their growth. It's a fairly fastidious organism. It may grow on conventional media, so blood agar or saccharide agar, but the yields improved when certain selective or enriched media are used. Examples like buffered charcoal yeast extract, modified TM agar, and your BHI broths. So these would be, if you really think it's there and you want to make sure you do isolate it. These are some of the caveats that we need to incubate it for longer and consider the growth on specific or enriched media. The overall sensitivity of culture ranges between 85 and 95% in most studies. Again, that second case was culture negative on the first, but perhaps was not incubated for long enough. The yield from a blood culture, even though we know that the disease tends to disseminate via the bloodstream, probably hijacking or hiding in macrophages, is pretty low, even in disseminated disease. I've personally never seen a positive blood culture for Nocardia. Again, for the micro, the speciation has undergone this major revision. It grows as these chalky white, dry, and sometimes cotton candy-like colonies, and it may also exhibit sort of a creamy or velvety texture. It can be pigmented, white, yellow, orange, and they tend to adhere firmly to the agar, and they have that like fungus-like mycelial, almost pseudo-fungal appearance sometimes on the plate that contributes towards the appearance. The speciation using biochemical reactions performs poorly, so this is not an easy thing to speciate in a conventional laboratory, whereas MALDI-TOF and perhaps molecular methods, especially 16S ribosomal or PCR, and even better multi-locus sequence analysis, so including 16S with a couple of other important housekeeping genes, those are probably the way you're going to identify the species most accurately. Certainly MALDI-TOF is available in most of the state labs at the moment, so that's something that one can fall back on to identify, assuming we manage to grow it. They interestingly have this characteristic complex, they can be sort of divided into characteristic complexes with a specific antibiotic susceptibility pattern. So going backwards, it was first described as Nocardia asteroides. That was the archetypal species, actually described in an animal by a vet. Asteroides means star-like. Again, this star-like appearance perhaps on the agar and named for Edmund Nocard. And then it was thought to have variants with different drug susceptibilities rather than independent species because it's difficult to phenotypically identify in a laboratory otherwise. And so on the far left, you can see this is from Mandel. There were characteristics, it was always in asteroides, which is now actually defunct, but with varying drug patterns. Now, the drug patterns are what becomes quite significant from a clinical perspective once you have speciation, and we'll discuss that further. So molecular methods demonstrate a much more complex and distinct speciation, and obviously that explains why you have unique drug susceptibility patterns. These are distinct species complexes. And as mentioned, the old name of N. asteroides is probably taxonomically defunct now. Although the problem with this is that it's undergone such an evolution in taxonomy, reading any older papers or older books becomes a real quagmire of trying to compare the old with the new. So this is from a nice review article from I think the year before last, of the commonly designated complexes. So you have abscessus, which is best identified by MALDI-TOF or gene sequences, the N-nova complex, N. transvalensis, which despite its name is actually not that common in South Africa, your brevicatena or Porcivorians complex, and then there's a couple of others. Otididiscovarium, which was described actually from a guinea pig's ear, and that's the origin of that really mouthful of a name. Syriac georgica, that one's quite self-explanatory where it was described, and then Forsynica. And these are sort of the broad 7 complexes that we consider now. So again, for the microbiologists, that would be how you approach it in the lab. You have a Nocardia species based on clinical appearance. You try MALDI-TOF, and if that's able to speciate, great. If not, then one generally would fall back on genomic sequencing. And the ways to do it include 16S or perhaps multi-locus sequence analysis to get the most accurate species. And again, that has the relevance within where it fits in a given complex, and perhaps the antimicrobial susceptibility pattern that will be for that organism. The epidemiology, well, this is difficult. I mean, there's no reporting system in place anywhere in the world. Some studies suggest an overall increase over the past 20 years, but I mean, that might be an increase in immunosuppressive therapy, an increase in survival in immunocompromising conditions, because we now know what to do perhaps after we give patients immunocompromise, and then obviously sampling bias as diagnostics improve, and we're obviously going to pick this up more. A crude estimate from a paper quoting US numbers, around 500 to 1,000 cases annually. So really a drop in the ocean. South Africa, it's not clear. There's a paper published by Tina Thomas. Well, it's not actually published, it's in publication, but they presented actually at a conference. And here there were 165 cases at the major reference lab, then at the Joburg Gen over a 3-year period. So not particularly common, but the question is obviously, do we miss it? Looking at particularly high-risk patients where there's aggressive diagnostics applied to this type of patient subset, if you look at transplant statistics in the States, the overall prevalence is about 0.6%. And if you specifically look at lung transplants, I know Jeremy's favorite form of transplant, the 3.6% prevalence in that population. So really that's where you start to really need to think about it. It does have some interesting predilections. So firstly, the age predilection is between 30 and 50. And it interestingly, in most studies, not all, seems to have a male preponderance. I've rounded up somewhere between 1.6 and 2 to 1, which is important. And certainly, I mean, this is anecdotal, but I don't think I've seen a female case with this condition personally. The species distributions geographically, again, probably is important because you want to know what empiric therapy to use, and that would be informed by your local epidemiology. Now, there are a number of papers on this from various parts of the world. Of course, they're all pretty small. The numbers are all fairly small, but there's a couple of papers. So if you look at China, for example, 29% of Nocardia fossinica and 23% Syriac georgica. If you looked at this was from a French study done not the year before last, again, Syriac georgica and fossinica, again, number 1 and number 2, the top spots. If you look at some places like the United States, here it gets even more interesting that it depends on which state you're in, which obviously makes some degree of sense. We know that this is an environmental pathogen and the environment has to support the growth of the organism. So in Minnesota, Nova would be the most likely isolate or complex to isolate, whereas in Arizona, you'll find Syriac georgica. And more interesting, if you go to sort of the tropics, you go to Florida, so they're Braziliensis, which we know from Madura foot as a cause, and perhaps that third patient I presented, that becomes the most important. So again, understanding the local epidemiology based on whatever limited data we have may inform your diagnostics, may inform your therapy. Again, this paper hasn't been published, and Dr. Thomas is unfortunately away, so I couldn't get the primary paper. She said it's in print. But this was they presented it at a conference, and basically they looked at the species epidemiology and susceptibility from 2019 to 2022. This updates a previous paper by Warren Lohman. And here the top 2 species countrywide were, in fact, abscessus, which is different to Prof. Lohman's paper, and Syriac georgica. And approximately 90% of isolates were susceptible to Bactrim, which is obviously important from a therapeutic perspective. If you look at the older paper, sorry about that, again, fossinica, small numbers, but fossinica and Syriac georgica were in fact the most common species distribution. And again, major differences in antibiotic susceptibility. The other utility in knowing what species you're going to get is because some species have a predilection for certain sites of disease. So for example, Braziliensis doesn't really disseminate. So it's almost always a skin and soft tissue focus, whereas many of the others are obviously predominantly pulmonary disease. Some have more or less of a predilection to disseminate to multiple parts of the body, including the central nervous system. This is half the table. I cut it off just because there are so many species that have subsequently been described. So what are the important drug susceptibility patterns? Again, you look at the big complexes, and some of the standout stuff for me is if you look at fossinica, it's inherently resistant to ceftriaxone, which often for CNS disease is a go-to drug. It's a fairly resistant isolate, which can be problematic. You're often left with minimal options in this isolate, including drugs like linezolid, which we know has some toxicity issues, and amikacin, which perhaps is not the best for central nervous system. If you look at our other common isolate, at least from the other 2 common isolates in South Africa, you'll see Syriac georgica is susceptible to ceftriaxone usually. okay, and susceptible to linezolid, and it's resistant to a number of the other oral options, including quinolones. Now, this up-to-date table basically says everything's resistant to quinolones. They used 80% based on the studies that they looked at. It's not entirely accurate, but what is important is what's emphasized at the bottom, that moxifloxacin hasn't been as well studied, but seems to have a different susceptibility pattern to ciprofloxacin, and so not all quinolones are created equal. This, again, just to demonstrate an important drug like imipenem, which was not covered in the up-to-date table. So here, again, abscessus, for example, is intrinsically resistant to imipenem, or at least more than 80% of isolates are. Similarly, Braziliensis, your cutaneous disease, might also be. If you look at local data, and again, there's not a fortune of it. So we discussed Dr. Thomas's patient paper, where, again, that we await that with bated breath, but this is from Prof. Lohman's paper looking at the susceptible and more resistant drugs from the isolates. This is from 2010, so about 14 years back. And if you look at the drugs that at least 100% were susceptible, amikacin, Bactrim, and linezolid in his study. Now, again, Dr. Thomas's paper reported 10% of Bactrim resistance. If you look at some of the other common drugs that we fall back on, imipenem is a stock standard for central nervous system disease. At less than 50% of the isolates here were susceptible. Similarly, ceftriaxone, you're edging towards 2/3. So a third will be non-susceptible. So again, important to keep these things in mind when you have a patient without yet having the species and susceptibility pattern, what to do. So obviously, caution, this machine has no brain, use your own. So again, these typical patterns are typical patterns and nothing more. And obviously each isolate may or may not have a slightly different pattern. But it is useful if all you have is the species name up front, which often is the case prior to having overt drug susceptibility, because it can take a bit long to grow and therefore identify the broth microdilution susceptibility. So it can inform empiric choice further. You can sort of narrow things down. Pathogenesis of this disease, well, as we mentioned at the beginning, usually it's mediated by an inhalation of environmental particulates, and this has some aerosolized bacteria. And then in those with perhaps a predilection or immunocompromise, they might have hematogenous dissemination, most commonly to the CNS, but also to various parts, skin and soft tissues. Certain other organs can also disseminate to, and it has this unique tropism for CNS tissue. Intracellular persistence in macrophages probably is why it's resistant to that phagosome-lysosome complex. So combined with some degree of immunodeficiency, these patients, where your T cells are supposed to mop that up, perhaps these patients will progress. The other consideration is direct inoculation. Usually this will result in a primary cutaneous infection. It might result in actinomycetomas, that horrible picture that you saw in the patient in case 3. Again, classically Nocardia brasiliensis. And there are obviously many, many, many other species of actinomycetoma and fungal organisms causing eumycetoma that also need to be considered in patients with that presentation. They can cause abscesses, cutaneous abscesses, multifocal abscesses via dissemination. It is one of the organisms that spreads via sporotrichoid spread potentially. If you get cutaneous inoculation on the finger or the leg, you might notice that lymphatic spread of nodules without ulceration. And again, that's characteristic for Nocardia species, especially Brasiliensis, Mycobacterium marinum, Leishmaniasis, and I'm forgetting one of the other really important, sporotrichosis, obviously. Intravenous drug use, again, in South Africa, we've seen a burgeoning epidemic of that. And no shortage of cases that I've seen with this condition have been people who inject drugs. And obviously that lends itself to an environmental organism seeding hematogenously to the lungs, to the CNS, and who knows where else. Conditions that affect cell-mediated immunity dominate, and the risk factors for nocardiosis among the immunocompromised result in a disseminated infection. So these patients, obviously, they have mycolic acid-rich cell walls with lysozyme resistance, so they survive within the phagosome-lysosome complex. That combined with either really dysfunctional neutrophils, so for example, your phagosome-lysosome complex is really defunct, for example, in rarer conditions like chronic granulomatous disease, or in the absence of well-functioning T lymphocytes, which will pick up via the antigen expression on the outside of these intracellularly infected cells and are important in removing or addressing intracellular organisms. So if you have a problem with your T lymphocytes, that's where you, or a severe problem with your granulocytes, that's where you tend to see this condition, at least the way it disseminates. Humoral immunity, not particularly important. So those things that have to do with specifically antibodies, our patient, the patient who received rituximab, ironically not particularly important, although rituximab often is not given in isolation. Adequate cell-mediated immunity aids in the development of the granulomatous inflammation, so you're more likely to see a mycetoma in a patient who has some degree of functional T-cell immunity. What are some of the classical risk factors? So the first thing is immunocompromise only accounts for 60% of patients with this condition. And again, as one would expect, solid organ transplants, especially heart and lung, more so than others, hematopoietic stem cell transplants, patients with cancers or solid tumors, various forms of immunosuppressive therapy, as we discussed, predominantly those affecting either your neutrophils or your T cell, your lymphocyte response, T lymphocyte response. HIV, which overall represents less than 10%, but obviously if you look at the South African population, I'm sure it's the vast majority. Chronic granulomatous disease or autoantibodies against your granulocyte macrophage colony stimulating factors. So again, things that really render your neutrophil oxidative burst problematic, and interestingly well described in ACTH-mediated Cushing's disease. Again, we know that endogenous excess of steroids, or exogenous for that matter, will obviously affect neutrophil function and specifically T lymphocyte response. Interestingly, up to 40%, according to some papers, are immunocompetent. Again, seemingly immunocompetent. If you take a deep dive, some of these patients have subtly immunocompromising conditions, alcoholism, perhaps some degree of organ dysfunction, chronic kidney disease, etc. But the largest chunk is in fact chronic lung disease, and it's been described in COPD, bronchiectasis, IPF, in fact. So that's obviously an important consideration. It will generally not disseminate in those patients. So these are patients where you're likely to see isolated pulmonary disease. Traumatic inoculation, again, as mentioned, obviously someone who's uniquely at risk for that, that's going to be a consideration. So a gardener, someone who's working with sort of the environmental reservoir of this organism and more likely to get poked, pricked, or have exposure to an open wound. And then there's male versus female predominance, which is not explained. There's papers that say estrogen is protective. There's papers that say estrogen is in fact harmful. But maybe it's exposure related. But that would need a deeper dive to try and explain. This was from a paper published in 2020, which again, I put it in because I found it interesting. It's from a paper from, I think, the Middle East. And if you look at these patients, that no apparent susceptibility makes up at least 15%. So patients who didn't have obvious chronic lung or immunosuppressive conditions. And obviously in this sort of different demographic, HIV is only a tiny percentage. But just to see that there's a fairly broad spectrum of conditions that on a spectrum immunosuppress the patient, starting with lung disease, probably mucosal immunity and the ability to clear this organism from the lungs itself, and then progressing sequentially to granulocyte or T-cell dysfunction, where you're more likely to get dissemination of disease and more severe disease. That's, again, important maybe in terms of therapy. What are the outcomes? So again, CNS and disseminated disease has a higher mortality than isolated pulmonary or lymphocutaneous. Apologies for the typo there. Again, limited data means that one has to squint at this. This is obviously from a single center review. But up-to-date quotes are 1-year mortality up to 25%. So this paper is quoted at 1-year mortality up to 25%. But that's obviously confounded by the fact that immunocompromised patients may well have mortality related to many other things. And then acute mortality in immunocompromised may be as high as 40 to 60%. So this is not a disease to be trifled with. And maybe some of that relates to delayed diagnostics. From this paper in particular, some of it correlates with mortality, which I thought it's worth looking at, include disseminated infection, that goes without saying, the presence of cavitation, perhaps an indicator of more severe disease, a more severe inocular, but it's not clear, the presence of pleural involvement, advanced infection, which they defined, I can't actually remember how they defined that. Your Charleston comorbidity index, again, made sense that would increase your risk. The presence of immunocompromise, again, goes without saying. And then, interestingly, Nocardia facinica, which increased your hazard ratio by 1.98. So and it's not the first paper I saw that sort of quoted this as a consideration. So there is what to be said, considering this is one of the more common isolates in a South African context. This particular isolate may have a higher mortality, and then obviously initial combination therapy is full of intrinsic bias based on you may have treated the patients who were sicker with more drugs. Apologies, I'm going to just open that. So let's go through briefly the three core presentations, some imaging from these types of patients. So obviously pulmonary disease is the most common clinical presentation of infection because inhalation is the primary route. The onset of symptoms has a spectrum as well, like everything else in this disease, and it may be subacute in your more immunocompetent type patient to, chronic in your immunocompetent type patient, or perhaps someone with isolated lung disease, to a much more acute to subacute presentation. And I'm sure those who have treated this disease have seen patients with fairly significant necrotizing type pneumonias, and the patients look quite ill. Thankfully, they usually settle quite fast. Again, classically productive or non-productive cough, shortness of breath, chest pain, hemoptysis, constitutional symptoms, and interestingly, it can cause effusions and an empyema. The chest X-ray can be variable. It can display focal or multifocal disease. It might have a nodular appearance, consolidation, and may well have cavitatory lesions. Interestingly, to try and differentiate this from TB, not so easy, but it does have less predilection for the upper lobes as compared to TB. So it's actually more common in the middle or lower lobes. And again, we know that with advancing HIV counts, advancing HIV disease with lower CD4 counts, we also see predilection for lower zone disease, perhaps, and less cavitatory disease. But if you do see cavities and they're sort of in the middle or lower lobes, and the patient has the appropriate risk profile, then it certainly should be on the differential list. And if one doesn't consider it, one might miss the diagnosis. And again, I'm sure we've all seen patients empirically given TB therapy when they have an X-ray that looks like TB, yet all the diagnostics come back as negative. Really something to keep in mind. It's often difficult, again, as mentioned, clinically and radiologically, to differentiate it from many of the other differentials that might cause a nodular or cavitary appearance. And again, especially the more immunocompromised your host, the wider the differential, and really the world can be your oyster. But certainly in a South African context, in an average patient living with HIV perhaps, then as a differential for mycobacterial disease in patients in whom the diagnostics are negative, one really needs to consider this. So again, just some varying X-ray appearances on the right-hand side, some consolidation, you can see a small air bronchogram, clear cavitation. Here you can see sort of, again, some lung destruction, multifocal small cavities. On the far left, extensive lung destruction, fibrosis, a trachea that's pulled all the way to the right. And again, this patient with a more nodular type appearance, perhaps. And again, it depends patient to patient and underlying immunosuppression. Skin and soft tissue disease, again, there's three core presentations that I'm going to briefly touch on. And again, as mentioned, these patients will develop the disease usually from an inoculation injury, like thorns, minor trauma that's contaminated, and certain species are more likely than others to cause localized skin and soft tissue infection. But they also might have manifestations of a skin and soft tissue infection as a feature of dissemination, and differentiating that is obviously very important. Patients with lymphatic spread, again, if your macrophages are harboring this organism, you might develop very similar cold abscess type presentations, often unusual locations, but again, the neck, the chest wall, femoral, these are all well described. And then occasionally it might be expansion from the lungs as an empyema necessitates, an empyema that sort of breaks through. So to go through these, that would be actinomycetoma. This would be Nocardia brasiliensis. So you get this granulomatous chronic response. It really can cause a lot of destruction of the skin and soft tissue. Interestingly, if it is actinomycetoma, if it is related to Nocardia, usually Bactrim works really well to resolve or improve the outcomes here. Those who have read around actinomycetoma, pneumycetoma, might have read that the grain color might, the grains that are extruded might give a clue to the etiology, certainly not hard and fast, but a white grain characteristically for Nocardia brasiliensis. What about that? Well, this is a patient's chest wall. This wasn't my patient. This is from a journal article. But again, a chest wall in a patient and a pus was aspirated, not that painful, but you can see it's pointing, so a chest wall abscess. And again, you can get abscesses at local sites of inoculation or as a feature of dissemination, as I would suspect a patient with chest wall abscess likely is. And then lastly, classical nodules with sporotrichoid spread. Again, the classical presentation of sporothrix but Nocardia, Mycobacterium, especially Marinum, and a subset of Leishmaniasis can give the same appearance, but somewhat pathognomic for those 4 organisms if you see it, and usually a marker of localized infection related to a distal inoculum. What about CNS disease? Well, again, I've shown you an MRI on the left, I've shown you a CT brain on the right, and you can see a rim enhancing collection, lots of edema on the right-hand side. The left one, there's 2 in this cut. On the right CT scan, there's at least 3 I can count. So these patients will present with a cerebral rim space-occupying lesion, which is almost always rim enhancing, and that's usually via hematogenous dissemination. Very rarely it's been described post neurosurgery, or post-traumatic skull fractures in patients with MVAs who are dragged through the soil and things like that. Again, the problem is if you see that CT scan in your average immunosuppressed population, you have an incredibly wide differential. And I think everyone on this call would have an approach to resolving some of these, but it's not so simple. We know it's not so simple. TB, could it be a pyogenic abscess, toxoplasma, malignancies, primary or secondary, certain stages of NCC, and many, many, many others. Again, so problematic and perhaps difficult to resolve. What's important is that 40 to 50% of patients with immunosuppression and pulmonary disease will be found to have clinical or subclinical CNS disease. And therefore, all patients with Nocardia, except those with clearly limited cutaneous disease, they need CNS imaging. What about some things to try and resolve Nocardia from other etiologies of a space-occupying lesion? Well, again, the male ratio and the presence or absence of immunosuppression doesn't really help that much. The absence of a fever, 70% or 65% don't seem to have a fever. Now, patients with pyogenic abscesses almost always are febrile. So that perhaps has some rule out value if you don't have a fever. Obviously, the presence not so useful. Other things, focal symptoms, seizures. So 50% of these patients will have focal symptoms or signs. A fifth will present with new onset seizures. What's interesting is also this, that the majority, 59% of patients had a single abscess, but up to about a quarter have multiple abscesses. And that's also important in terms of the likelihood of something being one thing or the other. Sometimes that may help. And then obviously, then uniquely, this multiloculated shape that it sometimes has, that seems to be somewhat unique. Again, not specific, but more likely in more than half of patients, it was a clinical cue or clue that this patient had Nocardia rather than one of the many other plethora of causes of a cerebral rim enhancing lesion. Obviously, I think MRI with diffusion-weighted imaging can help differentiate neoplasm from infection. But again, that's often where you get stuck. You can differentiate one or the other, but what is it? And obviously, in the absence of having a clear diagnosis, these patients would all need biopsy, culture, PCR. Interestingly, when it comes to neurosurgical drainage, these patients do best with open drainage, with a craniotomy rather than simply stereotactic biopsy. So open drainage and removal of this thick capsule improves the relapse rate or reduces the relapse rate. How do we diagnose it? Well, obviously, we need a high index of suspicion. We have to consider it. So again, where it may be on the cards, careful gram stain review. Sometimes the thinness of these filamentous organisms may result in them being missed, especially in sputum samples as an example, where you obviously have all sorts of other natural flora. And then many labs for pus and sometimes for sputum have a standardized protocol where they will use modified acid-fast staining. And that will, number one, pick up, perhaps improve the yield of pickup and differentiate patients with these filamentous gram-positive bacilli from actinomyces. And then lastly, you need to request or you need to tell the lab that you suspect this disease entity so that we have prolonged incubation on the right medius. It's generally always considered pathogenic. You isolate this obviously from a sterile site. There's no discussion. From sputum, there's always a discussion. And for the most part, one would assume that it's almost always pathogenic. But there are, again, there's at least 2 published papers I came across where there's some discussion of watchful waiting in patients who do not have a congruent presentation, because it may have been environmental contaminant or colonization. And obviously, in a patient who's well and you don't know why the sputum was done, there's a clear alternative etiology and X-ray that's not in keeping, the risk profile not in keeping. There's some consideration, although most texts suggest erring on the side of caution, and it's almost always pathogenic. And then an interesting thing, but because of the fact that it's not that common, there are some papers showing the development of an in-house PCR, which obviously will be useful for upfront diagnosis. There's a fair inoculum, and usually you would pick it up, but obviously there's no standardization, and these tend to be in-house assays developed by specific hospitals, labs, or universities. And then confirmation and speciation on MALDI-TOF or 16S PCR sequencing remains standard, and that's sort of what we have in terms of diagnostics. How do we treat it? Well, there's no shortage of retrospective reviews. If you look up on PubMed, you search Nocardia, you get over 10,000 hits, and you'll find lots and lots of case series, case reports, retrospective reviews, systematic analyses of sort of retrospective papers. If you filter that by randomized controlled trial, you get a single trial, which is still ongoing. And it's not even focused specifically on Nocardia, although it is an interesting one I thought to mention. Now, it goes without saying, we normally send these patients out on oral antibiotic treatment, but this is a trial looking at oral de-escalation for varying forms of intracerebral abscesses. Can we use it as step-down therapy for a pyogenic abscess, for Pseudomonas they look at in particular, and Nocardia is included in this study. Unfortunately, the study is still going, and I think anecdotally we know that we obviously use antibiotic step-down therapy for most of these patients eventually, although it can be tricky, you need to have the options. But that's the problem. There's very little randomized evidence. There's lots of consensus opinion. There's lots of retrospective data to sift through, but it's difficult. And I think everyone knows that that's one of the limitations of what to do when you're faced with this organism. So I'm going to just show from two great papers. I'll put the references a bit later. Sorry, this slide is missing the reference, but I'll mention it later. In terms of what you do, this is from a nice paper looking at a clinical approach. And again, the considerations are, and I need to turn on, don't know how to turn on a laser, but it's fine. The location of the disease, primary skin, for which you think is isolated pulmonary, for which you've excluded neurological, and then dissemination with or without CNS involvement. And basically it's stratified based on drugs that are likely to cover it, the number of drugs, and then obviously where one's worried about CNS involvement, one needs to consider the CSF penetrance of these drugs. So for simple primary skin disease, like for example, sporotrichoid spread in an immunocompetent patient, then monotherapy with Bactrim would be adequate as empiric therapy up front. And if the patient's intolerant to it, then linezolid would be another option. For isolated pulmonary disease, again, the suggestion is to use a Bactrim, a trimethoprim sulfenthoxazole backbone, and then add a drug, whether that's imipenem or amikacin, although we know that lung, that's not brilliant. Your ceftriaxone as another drug. So you basically consider at least two drugs for these patients, although monotherapy with a single drug is probably appropriate in a selected patient with non-severe pulmonary nocardia and no index of suspicion or exclusion of disseminated disease. What about your wasted patient who has multifocal abscesses, but your CT scan of his head is negative? So clearly disseminated disease, but your CNS involvement's been excluded. Again, here the recommendation is at least two agents, again, and one can consider all the typical susceptible antibiotics empirically. But where there's CNS involvement, here there's trouble, because here one needs to treat it up front. You need to treat it early. You need to reduce the relapse rate. Not all of these patients have access to neurosurgery, and we know that this varied susceptibility patterns might result in ineffectual treatment. So here the recommendations, again, they vary. If you look at this paper, you look at Sanford, you look at Hopkins, you're actually going to read slightly different things. The recommendation is, again, a Bactrim backbone, and then the addition of imipenem, which also leads to issues, obviously patients presenting with fits, but we know it gets into the CNS. And consideration of amikacin, although I must say, and those little stars suggest that it's probably not the greatest drug of choice, because we know its penetrance into the CNS is not particularly good. And an alternative that's given is linezolid with IMI, or in some texts meropenem. but linezolid IMI as an alternative for patients who are intolerant to the above. Then hopefully you get systematic species identification, which will usually come first, and then perhaps susceptibility testing. And then one can tailor therapy. Brain imaging needs to be done in all patients except for immunocompetent patients with primary skin disease. So that's the only exception. Everyone else gets some form of central nervous system imaging. This paper considers systematic CT chest for patients with nocardiosis. Again, assuming that you don't have clear pulmonary involvement, perhaps it might reveal it. I think that's something one can consider on a case-by-case basis. And then maintenance therapy, if an initial drug treatment was a multi-drug regimen with IV agents, you would continue, and this is entirely based on consensus opinion, for somewhere between 2 and 6 weeks, which is really a wide range, with more than one drug. Until and then once you've got susceptibility, then you would narrow it down to a single drug, and then hopefully, then you could switch to oral therapy. And again, the typical options might be Bactrim. They do not quote linezolid in this paper, but it certainly should be considered, although the drug side effect profile is problematic. Some are susceptible to quinolone, some are susceptible to things like tetracyclines. So again, based on your susceptibility. And then the duration. So primary skin disease, the recommendation is 3 to 6 months. Isolated pulmonary disease is 6 months. Disseminated disease without CNS, somewhere between 6 and 12. And the moment you have central nervous system, at least 9 to 12 months, possibly longer. Secondary prophylaxis is not indicated in immunocompetent patients. They have a fairly low risk of relapse once you've treated them properly. And just for interest, there's quite a lot of described breakthrough infections of nocardia on low-dose trimethoprim sulfamethoxazole prophylaxis, primary prophylaxis. So just to be aware that perhaps at prophylactic doses, it's not as efficacious at preventing this disease entity. Again, a slightly more user-friendly, or I thought just a nice flow diagram. Again, your diagnosis, is it mild or is it severe? 1 antibiotic versus 2 to 3. Are they immunocompromised? Yes, image the head, define the extent of the infection, get your species, and then adjust treatment according to species. And thereafter, once you have susceptibility testing, you transition to definitive therapy. And there's no clear benefit of more than one drug, assuming that it's definitive therapy and that is susceptible. Again, it doesn't project well, but just some of the common doses that are recommended for the drugs that one might use. And again, I refer everyone to this lovely state-of-the-art review published this year, which is really a nice paper to sort of give you a sense of this disease entity. It's quite holistic and draws on a fair amount of data, albeit we know the quality of data is questionable. But again, no shortage of options, but obviously the convincing ones, amikacin, but the nephrotoxicity and penetrance to the compartment of interest is questionable. Ceftriaxone is a lovely drug to use, but we know that South Africa, perhaps, only 60% of susceptibility. Quinolones, interestingly, ciprofloxacin is out, but moxifloxacin, there's evolving evidence that it's probably a good drug, and there's differing susceptibility. Ciprofloxacin resistance does not necessarily confirm oxyfloxacin resistance, and testing in vitro for this drug is a great alternative option. Again, we've used it in CNS TB, in patients with TB. We've used it, it's got good CNS penetrance, it's got good bioavailability, so a drug to watch perhaps. Again, there's a nice table that doesn't project well, but I recommend this is sort of the summary of everything from this paper in CID, in Clinical Infectious Diseases from this year, taking you through the at-risk, consideration, compatible signs and symptoms, confirmation, evaluation of the extent, confirmation of your diagnosis, and then treatment subsequently followed by prophylaxis if indicated. Some of the contemporary issues, and I'm doing this as a rapid fire, you'll get a slide and maybe 2 points because we don't have a lot of time and there are so many contemporary issues that one needs to consider. So one of the ones the microbiologists would love to perhaps make their lives easier, e-tests, so your gradient strips versus broth microdilution for testing susceptibility. This was actually the topic of Warren Lohman's paper, and we know that broth microdilution may be tedious and slow and usually requires a centralized site. So if you could use an e-test to identify appropriate susceptibilities in a timeous fashion, it may well be useful. But again, a poor correlation was shown. So this was the paper from 2010 by Warren Lohman et al. They suggest that in a routine diagnostic setting, the e-test is not an acceptable alternative to the reference method of BMD. Obviously, small study and more questions than answered, but a shortcut that would have been nice, we can't use. How long do I treat for? So if you pick correctly, you may get away with an even shorter duration, even in perhaps pulmonary disease. So that spectrum of 3 to 6, 6 to 9, 6 to 12, 9 to 12, always difficult. You know, when do I err on the side of 3, perhaps 2 months? When do I err on the side of clearly 6? This paper, again, published last year, showed that overall, if you pick and choose your patients well, overall, there wasn't seemingly a significant mortality difference or survival difference between those who were treated for 3 months, somewhere between 3 and 6, and more than 6 months. There's a lot of confounders in the study. It's obviously a single center retrospective study. And again, they comment that these individuals tended to have less immunosuppression, a more localized infection, lower proportion of CNS, and I'm going to highlight that N. falcinica as a causative species, once again rearing its head, so something to watch that perhaps confers a worsening prognosis or is a more virulent organism. So not clear, but probably one can get away with treating very mild localized pulmonary disease on the side of sort of 3 months. But one would have to really be cautious, watch the patient carefully, and that assumes that they are the perfect patient without immunosuppression, etc. So again, hard to say what to make of this paper. But it's important that it's being looked at, because obviously the duration of therapy is a problem. What about the dosing if you're using Bactrim or cotrimoxazole? We're probably systemically overdosing our patients. And again, I think we know that from pneumocystis. We know that the basis for the recommended very high dose is perhaps dubious. You know, certainly the 20 milligram per kilo here, the recommendation is sort of 10 to 15 milligrams per kilo for CNS disease, and then perhaps step down with 10 milligrams per kilo. But again, the CNS disease, most books and guidelines will say 50 milligrams per kilo, which is a high pill burden, obviously compounds the toxicity. And again, here's a paper published in Infection, where again, small paper, single center, and they looked at 91 patients with high, intermediate, and low dose, and they defined that as one would expect, sort of a less than 10, 10 to 15, and more than 15. And there was, ironically and counterintuitively, the intermediate dose had a lower risk of 1-year mortality than the high dose group. And the risk of recurrence, which is the big concern, was actually similar. Again, they did pick and choose patients. The patients tended to have limited pulmonary disease. So again, in that patient subset, having excluded CNS disease, perhaps 10 milligrams per kilo of trimethoprim, which is probably BD dosing for Bactrim, again, a better pill burden, is probably adequate. Again, but no randomized trials, and I don't have any PK trials for you. And last two, which drugs do we step down to? So again, we know that cotrimoxazole remains the standard of care. It's low cost, it's available. It's got a great proven track record in all sorts of things, respiratory conditions like pneumocystis and CNS conditions like toxoplasmosis, and cutaneous diseases abound, you know, for skin and soft tissue infections. So we know it's well tolerated, good bioavailability, but obviously there's a subset of patients who won't tolerate it, and especially at the higher dose, whether it's hypersensitivity reactions or whether it's things like prolonged use causing myelosuppression, causing electrolyte disturbances in patients with borderline renal function. So there are issues, and certainly it's not the only drug one needs to consider, and certainly if there's contraindications, a previous blistering skin eruption from this drug, then you can't use it. Drugs to watch, again, linezolid, there's a growing subset. Now, the everlasting question, standard of care would be 600 BD. Could you get away with a lower drug dose, as we've seen in TB? And these are unanswered questions, maybe someone will look at, but we know that the long-term toxicity and side effect profile is problematic. And then one of the newer relatives of linezolid, tadalafil, again, there are studies looking at it and looks quite promising. And then the other one I think that's worth watching, and it certainly gets a mention in a number of papers, is moxifloxacin. Again, because of the tolerability, and we know the CNS penetrance. And I think that's something that's worth testing, so that at least you have an alternative option. And perhaps, you know, again, this might be contentious, but in that empiric phase, perhaps if you're using two drugs, moxifloxacin and Bactrim, you could do an oral step-down switch earlier, given that they both have good bioavailability. But that would be off-label. What happens if they're not getting better? Well, source control, drain the abscess, drain all the abscesses, double check that their brain abscess hasn't reaccumulated. So source control, recheck drug susceptibility if they're culture positive. Certainly consider mimics, TB, anybody. And then I thought interesting, and just because it was topical with someone else I was speaking to recently, adjuvant interferon in recalcitrant cases in patients with immunosuppression, which I thought was an interesting, it's a single case, so it's certainly not something that's standard of care, but an interesting concept. And I leave you with this. There's a number of studies or papers, really nice review papers on the left, some microbiology studies, the state-of-the-art review, and how I manage Nocardia, similar to the hematology ones, how I manage. I really like the sort of structure and style of both these papers, and they're both published in the last 2 to 3 years. The evidence is fairly current. And then there's a lovely Mayo Clinic review, although it's about 8 to 10 years old, which again is nice and clear. For the microbiologist, certainly on the left, these are great papers to look through. And with that, I say thank you. This is apparently, if I believe the Instagram post, this is apparently Nocardia fossinica grown in culture.
Well, thanks, Leo. That looks horrific. Thank you really so much. That's an absolutely brilliant overview, I thought. And yeah, lots of questions, as you say, understudied to some ways. Just to punt those state-of-the-art reviews, the CID are doing one a month, and they're excellent. I mean, they really are. For each topic a month, really, I think almost required reading for infectious diseases. So I'm glad they've snuck one in for Nocardia, which is great. We don't have time for many questions, but Judy's got a very good one. She's asking about the lamb. She assumes it can be positive and can also make it hard to diagnose TB. You've obviously looked at that.
I didn't touch on it because I knew that I would run out of time. It was going to actually be the second to last slide, because I think those who know me know lamb's another interest of mine. But there's still a dramatic paucity of data, whether it's clinical or proof of concept. As far as I'm aware, the last time I did this literature review, granted that's about 1.5 years ago, there was basically a single paper that was looking at spiked urine samples, and found that Nocardia perhaps was one of the many things that can cause a false positive urine, using a very old assay, an ELISA-based assay, long before the point of care. So there's this everlasting question that I think has arisen: can Nocardia cause a positive urine lamb? And it's analogous to the discussion around non-tuberculous mycobacteria causing a positive lamb, that the patient subset is always so immunosuppressed. And again, I always quote Lawrence, Helen Joseph study, where the number of diagnoses in these types of patients is often numerous, not one or two. It's hard to tease out which patients perhaps have multiple diagnoses, and that becomes difficult. And I think you would have to be quite brave, although I know people have done it, to say, I'm not going to treat this patient for TB, I'm just going to treat them for Nocardia, and you watch them. And again, I think anecdotally, I think that there have been some good outcomes. And this is an area that we need to get our acts into gear, because I think we all have a fair amount of data. And I spoke about Dr. Thomas because she runs the reference lab, and it's a project that is on the back burner with her and myself to actually spike urine samples and see, using the more modern assays, and then correlate that with perhaps some case series. So again, anyone who does have case series of patients who they were convinced did not have TB, perhaps they were brave enough to not treat as TB, but confirm Nocardia with a positive urine lamb, these would be great cases to collaborate on and write up. But yeah, it's a question, Jeremy, I defer to you. What would you say?
I think we feel fairly confident it can do it. The question is just, what are the practical implications in a clinical scenario? In other words, there is lipoarabinaminin in lamb. It's likely that it does cross-react from in vitro data and from in vivo data. The challenge is, what do you do about the patient in front of you who has advanced HIV and has Nocardia and a positive lamb? Would you say he doesn't have TB? Because probably at least 30% of them will have TB, based on everything else we know, about our patients. And so that to me is a very hard decision. I mean, I think, like you said, if you're going to go without the TB treatment, I think you need to watch very closely. I mean, we have had one or two where we've done that and they've been fine, but we've also had one or two where we really thought it wasn't TB, and Ribka presented one. And then, the urine culture came back like a month later after we'd, test for TB number 12, the final one. And that was positive, so we had to sheepishly add TB treatment back. So I just think it's very hard in South Africa to say that. I think, if you're in a different setting where the pre-test probability of TB was much lower, if you're in a first world country where there's just not much TB, then I think the answer might be very different. But I don't, I think that definitely Nocardia can do it, and I think you definitely don't have to, but it's so hard to say it's not TB, in these guys. I don't have a better answer for you, I'm afraid. And then lastly, Ripka's got a question then in the chat for how well does Nocardia grow on commercial mycobacterial culture like Bactex? And then would they be called contaminated if they did? I see some people are answering already.
I mean,
So you're off the hook,
I know
Lior.
that the way in which they process, sorry.
No, go ahead, go ahead.
Now, I was going to say, I think the way in which they process mycobacterial culture, because we selectively are choosing to culture for mycobacterium in at least in South African contexts at the NHLS, they do significant, what's the term? Not sterilization, but they take steps, decontamination steps, and many of those steps are intrinsically harmful to Nocardia. Things like ACC, things like they use an acidic, like an acid of sorts. So again, the microbiologists certainly will be able to answer this better than me. But I did come across specifically, it was stated that many of the steps taken on sputum as an